All righty. Hey, everybody. We are live. We're sharing our screen. Um, how's everybody doing? Thanks for the people that are tuning in. This is Reid, and I'm here with the ECG channel. This is our first live. So, obviously, we are working through all the technology together. But if you have any issues throughout the video, just put it in the comments. I've got my comments here. I'll be following them. And I'm just super excited for your support. So thanks to everybody who is here. If you want to, when you tune in, shoot me a comment, say hi, where you're listening from. We've got viewers from all over the place. So it's exciting that we all have common ground in ECG fun. So today, I think you guys know we have 9 EKGs that we're going to go through. I've got them here. If you're wondering how you can follow along, I just wanted to show you quickly on my screen here how you can access these. So obviously here we're on the live video on my channel. And what we can do is if you go to my Patreon account, I set up a Patreon. It's a little bit easier for me to manage all the PDF documents and try to also just add some value to your ECG experience. So click join for free. I know you have to make an account. It's free. I'm not trying to make any paywalls for anything. And when you do join for free, I wanted to at least give you access to something on the Patreon. And so if you scroll down, you've got these daily ECG challenges. And I post every morning. See, this morning, 14 hours ago, I post a little clinical scenario. You can go in, look at the EKG. You can comment what you think the EKG is. And then the next day, I'll actually push the answer. So I've got a demo one at the bottom. So if you go there, you can see you've got access to at least just one. They let me do a demo. You can see what it's going to look like. You'll get an EKG, and then I'll post the answer. So exciting stuff. And without further ado, I think it's time to jump into some EKGs. So feel free, like I said, if you have questions throughout this, feel free to ask. I would love to go over a couple of tidbits for each rhythm. And we've got 9, so I can't do a full lesson on 9. So if I don't get to your question, sorry. I'm going to go through all the comments at the end. When the video posts, I'll make sure I answer whatever question that you had in the comments. So, alrighty. So let's start off with our first EKG here. And what you're going to notice here, we're going to do our normal approach. So first thing we're going to do is we're going to look at the forest, and the trees of our forest are the QRS complexes. And so when I look here, maybe I'll look at a rhythm strip, lead 2 on this EKG. And when I zoom in on lead 2, what you'll notice is we've got a wide, complex rhythm, right? If I zoom in, those QRS complexes are over 3 little boxes. The QRS duration is greater than 120 milliseconds, or 3 small boxes. And so I see that tells me that this is not taking the normal His-Purkinje system through our ventricles. So I instantly have to think of what's my approach going to be to this EKG. It's either an atrial arrhythmia, a tachyarrhythmia, because it appears to be fast. We'll calculate the rate in a second. But an atrial arrhythmia that either has an aberrancy, like a bundle branch block, or a ventricular arrhythmia, like a ventricular tachycardia. So we have to determine what kind of data we can pull from that. And so when I look at this EKG, I want to calculate the rate. So I find a QRS that lands on a solid line, maybe there. And I see my rate is 300, 150. This is 100. So maybe 140 beats per minute. So certainly fast. So we have a tachycardia. And when I look for my atrial activity, maybe that's the next thing I do is I start to evaluate my atrial activity. I look for P waves in front of my QRSs. And I say, I don't necessarily see any there. I don't know if I see any in V1. V1 is usually a good lead to look for your P waves. I know my P waves for a sinus rhythm would be usually upright in lead 1 and upright in AVF, but I'm not so sure I see really any good P waves. So I'm wondering, is this an atrial arrhythmia, like an SVT with aberrancy, or not? And so I start to determine, what is my QRS morphology? I'm going to kind of skip because I can't evaluate my PR interval. I can't really evaluate much if I don't see a P wave. And so what I'm going to do is I'm going to look at my QRS morphology. I'm going to look at the axis first. Now look at my axis is negative in all of my inferior leads, leads 2, leads 3, and leads AVF. If you notice, the QRS complex is negative in each of these 3 leads. Well, if I look over here, leads 2, 3 in AVF, if my QRS is negative, that tells me that my QRS is traveling from inferior to superior. And so that is really not typical of an arrhythmia or a rhythm, rather, that is coming from this AV node and traveling through the ventricles, even if it was conducted aberrantly. So that obviously makes me think this could be ventricular tachycardia. So now I'm wondering, is this ventricular tachycardia? And so we know ventricular tachycardia has a couple of EKG features that we can look for that will confirm the diagnosis. The first thing I want to look for and that I notice is that this is a monomorphic ventricular tachycardia. If I look at the QRS morphology, we would say this is, if it is VT, this would certainly meet the criteria for monomorphic, just meaning that the QRS morphology is the same. Okay. And something that interestingly happens in VTAC is we get some beats called fusion beats. And I see that we have this QRS that looks different from all of them right there. To me, that looks like a fusion. I'm probably going to spell this wrong. Fusion. I feel like that's not an H. A fusion beat. And what is a fusion beat? A fusion beat is when you have a beat that's arising from the ventricles, that's depolarizing through the ventricles in that wide QRS fashion. But we also at the same time have a beat that has come down from the SA node through the atria, captured by the AV node, and it just started sending that beat through as well. And so these two waves of ventricular depolarization will actually come and converge, and you'll get a fusion beat. So that's pretty good data or evidence that if there's a fusion, this rhythm is coming from the ventricles. So that fusion beat is very, very, very indicative of ventricular tachycardia. So we've got that fusion beat. Remember that in VTAC, there's a reentry circuit in the ventricles. And so when you get this reentry circuit that's coming through the ventricles, it's essentially every time it goes through, it suppresses the AV junction. And so you still can get atrial activity and atrial depolarization at the same time. And so you still get, you might still get P waves, but they're obviously not going to convert to a normal QRS complex. So something else you can look for is something called AV dissociation. And AV dissociation occurs when you have P waves that are occurring completely without any coordination with the QRS complexes. And so what you can do is you can actually scan through, and you can scan on these nice broad T waves, right? So here's our QRS, and then we have these T waves that are nice and slopey and broad. And what you can do is you can look for little bites or little peaks on those T waves. And so if I zoom in really closely here, if you look really closely, you can see there's a little bit of a peaky point on that QRS that is not with every other T wave. And so when you see that, you scan for more, and maybe I see a little more of a peaky point on that T wave. And even here, it almost looks like someone took a bite out of that T wave. And so sometimes if you see that here and there, that could be evidence of AV dissociation. So what am I going to say that this rhythm is? Well, I'm going to say so far with the evidence that we have that this is ventricular tachycardia, right? Our axis is negative in the inferior leads. We have a monomorphic rhythm, wide complex telling me it's not taking the His-Purkinje system. And we have a fusion beat, and we might have some evidence of AV dissociation. So the rate, 140 beats per minute, is certainly consistent with the ventricular tachyarrhythmia. And so that's what we're going to say that this rhythm is. So, all right, let's move on to EKG number 2. All righty, so same thing. Let's start where we always start, and we're going to look at the forest, and the trees of the forest are our QRS complexes. So maybe I'll come down here to, say, lead 2. And I've got a regular rhythm. If you look, I've got regular QRS complexes. And if I scan through the entirety of this rhythm, it appears to be so. Seems like I have P waves in front of my QRS complexes. So it seems like there is some type of atrial and ventricular coordination going on, which is important. My QRS complex, though, it does look a little bit wide. So if I look here, my QRS complex looks a little wide. My QRS is greater than 120 milliseconds, or 3 small boxes. And so that tells me that wide complex QRS. So when I see a wide complex QRS with potentially that is driven by the atria, like a sinus rhythm, I think of one, either a bundle branch block, or two, maybe another reason for an aberrancy, like an accessory pathway, right? And so we're just going to continue down our workflow. We're going to evaluate our atrial activity. So what is the atria doing? Let's see, I have my P waves here. My P waves, if I look in lead 1, you can see a little bit of an upright P wave in lead 1, maybe isoelectric in lead 1, but they're certainly upright in AVF. So that tells me that my P wave is going down and to the left. So this is certainly a sinus P wave. We know my sinus node beats at a pretty predictable rate, right? Usually 60 to 100 beats per minute. So if I calculate the rate of this rhythm, then let's see, we find a QRS that lands on a solid line. Like here, we get 300, 150, 100, 75. So in between 100 and 75, so maybe we'll call this 85 beats per minute. So far, this rhythm is certainly behaving like a sinus rhythm. If it's a sinus rhythm, we know that the AV node is going to capture that signal and send it down to the ventricles in usually 120 to 200 milliseconds. That's our PR interval. And so let's measure that PR interval and let's make sure that things are working the way they should. And so maybe I'll go here to lead 2. And so my beginning of my P wave here and the beginning of my QRS right there. So my PR interval is about 2 small boxes. I would say 80 milliseconds. Remember, we said that normal is 120 to 200 milliseconds. And so we have a short PR interval. That is certainly, we're going to put a down arrow for short, okay? And so what do we see, or normally what do we expect are causes of short PR intervals? Well, we're going back to our differential diagnosis, potentially an accessory pathway. What does that mean? Well, we know that the AV node doesn't get better than 120 milliseconds. And so, like I said, if my SA node sends signals down, get that nice P wave depolarization, my AV node is going to capture that signal, delay it by 120 milliseconds, and send it to the ventricles. But if, say, somebody has an accessory pathway, or another academic term for it would be a bundle of Kent, you have this connection that essentially a breach in the cardiac skeleton, where some of these signals can bypass the AV node and go into the ventricles. And what happens when they go into the ventricles? Well, they're going to depolarize the ventricles. But notice they're depolarizing it not using His-Purkinje fibers. It's going to be a wide, slurry start to ventricular depolarization for the first 40 milliseconds until our AV node is done delaying it and passing signal down. So this initial delay in that signal actually is what causes what we know is the delta wave. The delta wave is when you have a P wave and then the QRS slurs at the beginning and then you see the rest of the QRS is sharp, right? And so this portion is our delta wave. And so we see here delta waves. So that kind of confirms right after these P waves, we see these delta waves. So we have an accessory pathway, or another word for that is a pre-excitation syndrome, right? Another term for this is Wolff, Parkinson, White syndrome, right? The ventricles are pre-excited. And Wolff, Parkinson, White, I think, are the 3 physicians or scientists that determined or discovered this. So that is our accessory pathway. But we're not done. What we can do is we'll continue to evaluate our QRS morphology and everything else. Usually in pre-excitation syndrome, your axis is going to get a little bit skewed from normal. So if we look at our QRS axis, our QRS is upright in lead 1, and it's upright in AVF. Certainly a leftward axis, it seems, in the sense that we've got this pretty high voltage in AVL. So certainly more on the left side of our normal axis, but it's still a normal axis. We can still take a look at the rest of our conduction system. We see we lose our septal R waves. That's really just a function of our accessory pathway. So what are we going to get here? We look at our QT intervals. We see here's a QRS, here's a QRS, dotted line in the middle. Our T wave ends before the end of the middle of the R to R intervals. So we see our QT front eyeball perspective is normal. And we put all this together, and what do we get? We get a sinus rhythm at a rate of 85 beats per minute with evidence of pre-excitation or Wolff-Parkinson-White. What are we going to do with this patient? We're going to send them to an electrophysiologist because this bundle of Kent can be ablated, right? We can do like a radio frequency ablation where an electrophysiologist can map out this structure and go in there and take it away, essentially just burn it with a little bit of radio frequency. So it's pretty effective. And so that is our pre-excitation syndrome. All righty, let's go to our next EKG. So this is a patient here. Let's do what we always do, and let's look at the forest. And trees are our forest, are the QRS complex. And so maybe I'll come down here to V5. And so what I'll do is I see I've got this narrow complex rhythm that seems to be quite regular, and you can see it's regular throughout the entirety of the rhythm. If I find a QRS complex that lands on a solid line like this one, I could see what the rate is going to be: 300, 150, 100, 75, right about 60 beats per minute. So it's a normal rate. And so now let's figure out, is this a sinus rhythm or not? So I look for P waves, and I see I've got P waves in front of all of my QRS complexes. My P waves are upright in lead 1, and they are upright in AVF. And that tells me that my P waves are being generated by a force in the atria that are going down and to the left being positive in lead 1, down being positive in AVF. And so that tells me that, yes, this is a sinus P wave, right? The morphology of that P wave, the rate of that P wave all tells me that this is a sinus rhythm. So now we've evaluated the start of our SA node depolarizing the atria. What happens when that signal gets to the AV node? Well, we know it delays it. And so let's evaluate how the AV node is working. And so I see here, beginning of my P wave, we'll use this one in V1. My beginning of my P wave is here. Beginning of my QRS is there. Looks like maybe 4 small boxes, and each small box is 40 milliseconds. So 40 times 4, we get a PR interval of 160 milliseconds, which is normal. This is just a snapshot in time. So we need to look at all of our PR intervals. And so I scan through, and I see all my PR intervals stay the same. And I also need to scan through the baseline of this and just make sure that there's no extra P waves that don't have QRSs, right? So I don't see any, and so I do that through the rhythm. So I have a nice sinus rhythm with normal AV conduction. Alrighty, so the next thing we're going to do is we're going to go and look at our QRS morphology, right? So the AV node releases a signal down into the ventricles, and so we have a narrow complex rhythm, right? Let's see, the interval of our QRS is less than 120 milliseconds. So that is a normal QRS complex. My QRS axis is upright in lead 1. And if I look at AVF, it looks downward in AVF. And I would say it's more or less isoelectric in lead 2. So let's work through that. It's isoelectric in lead 2. In lead 2, I'll draw it in green. Here's lead 2. And isoelectric means that my QRS axis is going to be perpendicular to lead 2. Now I need to figure out which way perpendicular to lead 2. And so I look at lead 1, I see it's upright, I see AVL is upright. And so what does that mean? It's going towards 1 in AVL, right? So we would say we have at least here a left axis shift, right? Left axis shift is like 0 to negative 30 degrees. Anything greater in this region would be left axis deviation, right? So we have a left axis shift. And what are causes of left axis shift? We can have bundle branch blocks, but we don't have that here because we said our QRS is less than 120 milliseconds, which is normal. We could have fascicular blocks. Or we could have, say, a history of a myocardial infarction or current myocardial infarction or ischemia that's driving forces away from that ischemic area, because ischemic areas can't conduct signal. So keep that in our mind. Let's look at our R wave progression here. If I look in V1, I see that we have our nice little septal R waves. And those R waves grow and grow, and they grow nicely through V4, V5, V6, maybe a little bit of an early transition to V2, but compared to V3, it might just be lead placement, right? We expect that R wave to grow and the S wave to get smaller. So this thing grew a little early. I bet it's from lead placement. We'll see. So now we're going to look at our QT interval. And remember, our QTs, I just like to eyeball them. They're a function of rate, right? So when we correct for the QT, we correct it for the rate. So if I look here, I have a QRS that lands on this solid line, a QRS here. If I draw a dotted line right down the middle, in between, we'd say the R to R interval, you can see that the T waves are ending well before the midway point of those R to R intervals. And so, I think that just erased all of our drawings. That's okay. The T wave ends midway through the R to R interval. And so we would say that my QT is good. So what do we have now? We set our sinus rhythm. We said we have left axis, right? And so now the last thing we need to do is look for pathological Q waves and ST or T wave changes throughout the rhythm, right? And so we said when we have this left axis that maybe it could be caused by ischemia. And so I scan through my anatomic leads, and what do I see? Well, I do see some ST elevation here in lead 3, in lead AVF, and in lead 2. We'll zoom out so you can see that a little bit better. How do we measure the ST segments? Well, what we'll do is we draw our baseline here, and then you see the ST segment is elevated, right? Baseline, ST segment. And so same thing in lead 2. Here's our baseline, and there's our ST segment. And not only is the ST segment elevated, but you can see we have these, what we would call hyperacute T waves. A hyperacute T wave is essentially what we would call a convex shaped T wave, right? Where instead of being upsloped, and this would be concave, what you actually see is this T wave here. We'll just look at this one, where you see it's convex, just like that, like an upside down U, right? That's another sign of ischemia or infarction. So we've got ST segment changes. And what you also notice is if I look at these inferior leads, something else that's a little bit scary is you've got these Q waves in the inferior leads as well. We've got Q waves in those inferior leads, and those Q waves in the inferior leads tell me that forces are unable to travel to the inferior portion of the myocardium because there is some type of ischemia or infarction that's going on there. So they try to go that way, but in reality, they only can go to the left. And that explains why our axis is different. So we said we have inferior ST elevation. And if there's inferior ST elevation, which I'm going to use this green signal as maybe a sign of ischemia or infarction that's being displayed by our ST elevation, we should see reciprocal changes in the opposite leads of AVL and lead 1. We should see ST depression, usually more so in AVL because it's more aligned with the inferior leads, really lead 3. And so if I look up here, and if I look, say, at AVL, you can notice that we've got this QRS complex with a little bit of ST depression, right? That inverted T wave with a little bit of ST depression. And so that's pretty good data that we also have some reciprocal changes. We would call that reciprocal ST depression in AVL, and to a smaller degree in lead 1, right? Now we're thinking we have an inferior STEMI. Is this a right coronary artery or not? Something that we also can do is we can look here in V2, and we can see that in V2 we have this QRS, but we do have a baseline, and look at that ST depression in lead 2 or V2, excuse me. And V2 is sitting, if I put it on my chest, V2 is sitting kind of on this anterior portion of my chest, right? It's sitting really on my left sternal border. And so imagine if I had a posterior STEMI, I would be reciprocally creating ST depression in those anterior chest leads. And so this is actually representing posterior involvement. And so when we get posterior involvement with inferior changes, we have an infraposterior STEMI, which tells me this is really likely a right coronary artery occlusion. So this is all pointing to RCA occlusion, right? Because the right coronary, it will supply the inferior aspect of the myocardium, the right side of the myocardium, which is why we see more ST elevation in lead 3 greater than lead 2, right? Because lead 3 is more on the right side. And then we get posterior extension because the right coronary artery also supplies the posterior descending artery 80% of the time. So 80% of people that have an RCA occlusion, there is going to be some posterior involvement if they are what we would call right dominant. So put this all together, what do we get? We get a sinus rhythm at a rate of 60 beats per minute. We have pathological Q waves in the inferior myocardium, which tells me that there is some kind of almost late presentation of this STEMI, because if they can't conduct in that direction, that's because those tissues are already, we would say, unaffected, like not effective. They're dead. So maybe this is a later presentation for this RCA occlusion. And so hopefully this person got reperfused and did a little bit better. So let's head on to our next ECG. Hey, everybody. I'm looking at the comments. We've got somebody from Colorado, South Africa. Let me know where you're from, and also let me know what you want to see on the channel. I know got to do some STEMI lectures. I am in the process of writing that, but a lot of fun content. I love putting out ECGs for you guys to get repetitions. So really, I want to just get reps after reps after reps, and it just starts to become just seared into your brain. When you look at an EKG, you can just see the answer, and then you have your workflow to make sure that you don't mess or miss anything that's important. So, awesome. We've got somebody from North Carolina. That's great. So we've got North Carolina, we got South Africa, we've got Colorado. Thank you all so much for participating in the channel. If you're just logging in, head over to my Patreon and you can download all of these for free. Just join for free, and we'll go from there. So, all right, let's jump into this EKG. And this is a fun one. Looks a little wild when you look at it, but let's work through it. So the first thing we're going to do is we're going to look at the forest, and the trees of the forest are our QRS complex. And so what I'm going to do is I'm going to look here at lead V5, and you're going to see I've got a pretty rapid rhythm. It's pretty rapid, kind of slows down for a second, then it gets fast again, and it's pretty quick through the entire EKG strip. I don't really know how you guys like to calculate rate, but for an irregular rhythm like this, the best way that I find to calculate rate is this is a 10-second ECG strip. And so what you can do is you can count the number of QRS complexes, multiply that by 6 to determine how many total beats that you have in 60 seconds. So we can do that here. We've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24. So we have 24 times 6. Let's see how my math is on the camera. So that's going to be 20 times 6 is 120. 6 times 4 is 24. So 144 beats per minute. So we've got a fast rhythm, right? This is a tachyarrhythmia. And it's a wide complex rhythm, right? If I look, my QRS complexes are certainly, my QRS is certainly greater than 120 milliseconds. So it is a wide complex tachyarrhythmia. So we're thinking, is this ventricular tachycardia? Is this some type of atrial arrhythmia? Well, when I looked at my R to R intervals, we saw that they were irregular, right? We have some of them that are like really close together. We have others that are farther away. We've got some that are kind of in the middle of what that is. So I look for some type of pattern in the irregularity, and I don't see any. So I wonder, is this maybe an atrial fibrillation or AFib with aberrancy? Right? And aberrancy meaning is there like a bundle branch block? So my mind goes, let's look for bundle branch morphology. And what I notice is in the lateral leads in V6, V5, you see I've got this R wave, and then I've got this R prime. Right? Notice this R prime in my lateral leads. And that R prime is telling me that we have late forces going towards the lateral aspect of the myocardium. Well, that generally happens in left bundle branch blocks. Why? Because if my left bundle branch, which is this branch right here, is blocked, then signals that come down the AV node through our His-Purkinje fibers, when they try to get down the left bundle, it gets blocked. And when it goes down to the right bundle, it gets a nice wave of depolarization through the right ventricle. And then we get slow cell to cell through gap junctions traveling through to the left aspect of the ventricular myocardium. And that's why we get those late forces, because we're seeing this x-axis is time, late forces as an R prime towards the lateral aspect. So we certainly have what I would say is a left bundle branch block morphology. And so when you see that, what we think is this maybe AFib with a left bundle branch block? Well, what else we're going to see in a left bundle branch block? We're going to see the loss of septal R waves in V1. So you can see we've lost the septal R waves in V1. Sometimes you can see a little septal R wave. Maybe there's a little bit of a transient improvement from beat to beat. But we see we have lost our septal. We do not have our septal R wave. We know that the left bundle supplies the septum with fibers for depolarization. And so that's what our R wave is in V1. So far, everything points to the left bundle branch block. I look for atrial activity, and I don't really see any good discernible P waves that are in front of my QRS complexes. In fact, I see a little bit of a mild fibrillatory baseline. So really, this is all pointing towards atrial fibrillation. I really want you guys, when you're looking at these rhythms, to think of, do I understand the cardiac physiology? And then use that as a framework, right? I give you these 6 steps, but those steps really hinge on your ability to work through how the heart works, what conduction can fail, and how to identify that. So we've got an atrial fibrillation with a rapid ventricular response, right? We said our rate response. We said our rate is 144 beats per minute based on our calculation. And we have a left bundle branch block, right? This makes sense, right? Are we thinking, is this ventricular tachycardia? Ventricular tachycardia, especially monomorphic VTach, right? Because this will be, if it was, it'd be monomorphic. The morphology is the same. That is a very regular rhythm. Monomorphic VTach is regular. So we don't see that here. We've confirmed AFib with a left bundle branch block. Alrighty, so now we're not done. We need to evaluate our QT interval. So what do? We can go and measure from this R wave to this R wave, a dotted line halfway through. And you can see that my T wave, which I'll do in blue, ends by the 50% mark of that R to R. So we would say our QT is good. That's my QT eyeball test, right? Remember, QT is a function of rate. So we've done that. Our QRS axis, let's go through the rest of this. We said it's left bundle branch block, but let's just make sure. Let's look at the axis. My axis is upright in lead 1, and it is upright in AVF. That tells me that I've got a normal QRS axis that is down to the left, so that is good for my axis. We look for pathological Q waves. You're going to see a pathological Q wave in the septum because we lose our septal R wave. Otherwise, I don't see any pathological Q waves that are indicative of previous myocardial infarction here. And then we look for active ST and T wave changes throughout. Well, in a left bundle branch block, the issue with looking just for the normal ST elevation that you see in, say, in our previous strip where we looked at STEMI, the issue is that bundle branch blocks have something called ST and T wave strain. Right? That's because when you alter the the normal conduction system, you're also going to alter after an abnormal depolarizing wave, you are going to also have an abnormal repolarization, right? And that's because those Purkinje fibers are no longer sending the signal to the left side of the heart. So you're going to get this strain pattern. And so that's when you see, for example, here, you see we've got this upright QRS complex, but then you have this downward strained T wave. Usually the T waves follow the usually the T waves follow the QRS axis, right? So if the QRS is upright, the T wave is upright. So here we have a strain. So what do we do to evaluate ischemia or infarction actively in this? We have a criteria, and that criteria is called Scarbosa criteria, right? And so that's essentially a system. I'm going to make a video on that. I'm not going to go over it now. It's just essentially there. You can look it up. There's also a Smith modified Scarbosa criteria. That's a little bit more. It's a little bit just better performance in evaluating the specificity of changes. Essentially, you can predict the amount of strain and determine if the strain is appropriate or if we're seeing increased changes in the ST segment from ischemia or infarction. I don't see any of that here, so we're not going to call that. And so the last thing we're going to do is we're going to put it all together. What do we get? We have AFib with RVR at a rate of 144 beats per minute with a complete left bundle branch block. So this person, this arrhythmia is fast. They might be syncopal, lightheaded. And we know that the RVR is a function of these fibrillatory waves going through the atria, bombarding the AV node, and their AV node is sending signals down all the time, right? It just keeps getting bombarded. So if we slow the AV node down in AFib, if we slow this down with calcium channel blockers like diltiazem or verapamil or beta blockers or other antiarrhythmics like amiodarone, digoxin, if you slow the AV node down, then you're going to slow down the ventricular response. So before we head over, question, how can you distinguish this from Wolff-Parkinson-White? I thought those QRS in the rhythm strip were delta waves. So when you have Wolff-Parkinson-White, if somebody had Wolff-Parkinson-White, which remember Wolff-Parkinson-White is an accessory pathway. So good question. If say we have an accessory pathway here, in Wolff-Parkinson-White, you essentially, if you have AFib Wolff-Parkinson-White, you are going to have just continuous signals heading down into the ventricles, right? Because if they're in AFib, you've got these fibrillatory waves all throughout the atria. The AV node actually in AFib is very protective. The AV node delays the signal between beat to beat so that the ventricles have time to fill up and then squeeze, and then have enough time to fill up and squeeze. So in AFib with RVR, the AV node is still being protective of the ventricles. If we had an accessory pathway, it doesn't have those properties to slow down signal that is being sent to the ventricles. So a couple things with AFib and Wolff-Parkinson-White, you are going to have a very, very rapid rate, right? Because these fibrillatory waves are just going to be sending signals down consistently. Those fibrillatory pathways are fast in the atria, and they're just going to keep bombarding this system. And so you'll get rates, over 200, beats per minute oftentimes. Also, something else that you'll see is you're going to still see the irregularity. So it's still going to be very irregular. If you notice here, a left bundle branch block, the initial wave of depolarization that we see through the ventricles is still through the right bundle. It's still through the right bundle. And so you can still see the initial wave of deflection on my QRS complex. We'll look here in lead 2. That initial wave is still sharp. It's still sharp. Look in V1. It's still sharp. However, it then slurs towards the end, right? That's the slurred portion. We'll do it in green. That's the slurred portion is the second half. So in a bundle branch block, you're going to have sharp initial deflections in the QRS complex because that initial wave of depolarization is through the His-Purkinje system, and then you get that cell-to-cell depolarization through the ventricles. Next, in Wolff-Parkinson-White, the initial wave of deflection is going to be slurred. So Good question. In this case, sometimes that sharpness of the QRS is a function of time. The more of these that you see, the more comfortable, because there's no criteria of like, there is some criteria actually, but there's how sharp, right? And so I would say that really just getting comfortable with left bundle branch blocks and then some Wolff Parkinson White. If you actually look back, we'll go back to the Wolff Parkinson White EKG just so that you can see how slurred the initial portion of that QRS is. That initial QRS is really slurred. And then it picks up into sharp. So in Wolff Parkinson White, it's slurred first, then sharp. In bundle branch block, it's sharp first, then slurred. The physiology of that is because in bundle branch blocks, you start with depolarization through the His-Purkinje system. In Wolff Parkinson White, you start with accessory pathway and aberrant depolarization. So I hope that helps. Another question, what age group of people present with Wolff Parkinson White? Some people can live their entire life where the bundle of Kent that we talked about, that bundle of Kent, which say it's right here, some people's their bundle of Kent does not conduct that fast. Also, some people's bundle of Kent can only conduct anterograde, which would be this direction. Some people's bundle of Kent can only conduct retrograde. Some people's can do both. So some people present really, really early in life with developmental heart defects, just where that cardiac skeleton didn't, they all have a developmental defect or the cardiac skeleton doesn't form. But realistically, it depends. If someone develops AFib, then, in their 60s, that could be the first time because they have AFib with its accessory pathway. Or some people in their 20s are having palpitations. It's really variable. But great question about what age group of people present with Wolff Parkinson White. So, alrighty, great questions. Keep them coming. I love the questions. This is why we're going live. I wanted you guys to get a better experience with EKGs. So thanks so much. Let's jump into the next one. So here we have EKG. And so the first thing we're going to do is we're going to look at the forest of this EKG and the trees of my forest or my QRS. And so I'll come down here to V5. We see I've got a rhythm that is regular. It appears to be narrow complex, right? My QRS looks narrow. I see I've got this funky beat. Looks a little funky. I'll do it in red arrows. I see I've got a couple of those throughout the strip. Looks like 3 of them. But the rest of my QRS complexes seem to be on the same morphology and regularity as normal. So we'll look at the rate in between my 2 normal QRS complexes. We'll find a QRS that lands on a solid line, maybe this one right here, and pretty close. We'll say 300, 150, 100, 75. So maybe around 75 beats per minute for our normal QRS complexes. And you can see that these funky beats really aren't changing the rate. I'm just going to call this around 75 to 80 beats per minute. So I see P waves. If I look closely, I see some P waves before my QRS complexes. And if we look at what is the atria doing here, the P wave morphology is upright in lead 1, and it is upright from AVF. That tells me that my P wave axis is going down and to the left. So when my atria depolarizing, it appears to be coming from the sinus node. Remember that the sinus node is high in the right atrium. So when it is causing the initial shock wave to spread throughout the atria, you're going to see a P wave that is generally upright in 1 and upright in AVF, because that is our down to the left quadrant. We're kind of blocking it off. So this is a sinus rhythm at a 75 beat per minute rate, but let's make sure that those P waves and those QRSs are talking correctly, and it talks via our AV node. And so we measure our AV node via the PR interval. So let's look here, maybe in lead 2, and I see the beginning of my P wave, the beginning of my QRS, and it looks like maybe we're going to call it 4 small boxes. So my PR interval is 160 milliseconds. Normal PR intervals are 120 to 200 milliseconds. And so that is a normal PR interval. It tells me that my AV node is delaying this signal appropriately. And so now I need to make sure that every P wave has a QRS. Just because this one does, doesn't mean that everyone does. So what I do is maybe I'll come down to V1, and I've got these nice sharp P waves that are marching through. They're with every QRS, but I just want to make sure that in between these beats, there's no extra P waves, right? There's no PACs that are blocked. This is not a 2-to-1 rhythm. I don't see that, right? I scan through. I don't see that. Alrighty. So now we're going to look at our QRS morphology. Let's just look at the regular QRSs, and then we'll come back to our funky beats. Our QRS morphology is upright in lead 1. It's isoelectric in AVF. So that tells me that's going towards lead 1 and it's perpendicular to AVF. So here's AVF. If it's isoelectric, that means it is perpendicular and it's going towards lead 1. So our axis is about 0 degrees. So our axis is normal. That's a normal limit axis. My R wave, I see I have a nice septal R wave that progresses nicely through, maybe a little bit of a late R wave transition. Usually we want that R wave to become dominant in V3 or V4. It looks like it becomes dominant in V5. That's really not that wildly different of an R wave progression. So nothing that is jumping out at me. Last thing we're going to do is we're going to look at our QT intervals. We can do that by tracing out an R to R. So here's R wave. Here's another R wave. Midway through that R to R, and you can see my T wave ends before that mark. And so I have a normal QT interval, kind of eyeball adjusted for the rate. We're going to look for pathological Q waves, which tells me there's previous infarction in any of the ventricular regions. I don't see any. We're going to look for ST or T wave changes that indicate ischemia or infarction. Yeah, I see maybe like these mild T wave inversions in the lateral leads, kind of this flat T wave here. Nothing that jumps out at me. You can take serial EKG. It really depends on the clinical scenario. This might just be their baseline. You could have another EKG from 2 weeks ago, 3 weeks ago, 2 months ago, 2 years ago that looks just like this. Great. Check. Move on. And then the last thing we're going to do is we need to figure out, before we put it all together, is we need to figure out what are these funky beats. And so when I look, I want to determine if, say, here's my previous beat, here's the next beat. And if I determine when this beat came, I would expect the next beat to be right here, but it's early. So this is a premature beat. It's a premature beat. And when I have premature beats, I think either a premature atrial contraction, a premature junctional, or ventricular contraction. Well, we can look at the QRS morphology. You can see that the QRS that is generated in this is a wide. It's a wide QRS. It tells me it's not taking the normal His-Purkinje system. And so I want to make sure that this is not, I need to rule out PAC with aberrancy. So what I do is I look in front of my QRS and I look for a P wave. And I'm going to say P wave, question mark. Is there a P wave? And I don't see P waves. And I look before all of them and I don't see P waves. So there's no P waves. It's a wide complex beat that's premature. And if you look at the morphology, it does not match a morphology of any bundle branch block or aberrant conduction. And so what are you going to say this is a premature ventricular complex. So PVC. And when PVCs occur in a pattern, aka in this case, every fourth beat, you have a PAC or PVC. You have 1, 2, 3, and then your fourth beat is that PVC. 1, 2, 3. Fourth beat is a PVC, and that happens throughout. We would say this is in a quadrigeminal pattern. I probably need more space to write that. Quadrigeminy or ventricular quadrigeminy. So let's put this all together. What do we get? We get a sinus rhythm at a rate of, what do we say, 75 beats per minute with ventricular quadrigeminy. If you wanted to dive a little deeper, say you wanted to look at the morphology of these QRS beats that are the PVCs, you can almost map, you can map them out and determine exactly where they arise in the ventricles. And so given the clinical context, PVCs can be produced by a million, different causes, and just an excited region of the ventricles that is popping off every fourth beat. And if it's bothersome to people, you can ablate it. If they have a history of VTAC, this might give you clues into where that VTAC is coming from. You can go from there. So good job to Illusionate. Looks like you already had it. So good stuff. All righty. Next EKG. For those that are just tuning in, welcome. Let me know where you're watching from, just because it's fun for all of us to connect in the common ground of EKGs. And don't forget that you can head over my website, which is now on Patreon, the reason why I do that is it helps me upload and organize the PDF documents that you can download these. And I figured if I was going to ask you to make a free account, why not at least do something? And so I have the daily EKG challenge. And really what that means is I post every morning at, first thing in the morning, I post, at least my time, I post an EKG. It's got a little clinical vignette, like a 20-year-old with palpitations or a 60-year-old with chest pain or whatever. And I don't give you the answer. But the next day when I post the next EKG, I post the previous day's EKG's answer into the comments of that EKG. So if you want to go in there, there's already, I think 9, maybe today's day 9, because I'm doing all 9 of them right now in this video. And if you sign up for free, you get access to all the previous ones. So ideally, in a year from now, we've got 360 EKG quizzes, all sorts of free PDF downloads. You just got to sign up for free. Thanks. It's really the best way for me to provide these things and not miss it, because I don't want to say, hey, download the PDFs, and then I didn't do the right thing. So it just helps me hold myself accountable for you guys. So welcome, everybody. All righty. The next EKG here, let's dive into it. So first thing we're going to do is we're going to look at the forest. Trees of those forests are my QRS complexes. And so I maybe come down here to a rhythm strip. I have a V5 rhythm strip. And if I zoom in, we see we've got a regular rhythm. Seems to be fast. We'll calculate the rate in a second. And that rhythm stays regular for the entirety of the strip. And so my rate of this rhythm, I find this QRS seems to kind of land on this, at least the S wave lands on that solid line. We go 300, 150, that's 100. So just in front of in between 100 and 150, we'll call this maybe 110 beats per minute. So we have a tachycardia or tachyarrhythmia. It's regular. And my QRS seems wide. When I look at my QRS complex starts here, ends there. My QRS is greater than 120 milliseconds. And so that tells me we have a wide complex tachycardia. We have a wide complex tachyarrhythmia. It's regular. So what is I need to start developing a framework so that when I go through these steps, I can confirm or deny or alter kind of the amount of weight I'm putting into each of my differential diagnosis. And so I might think, is this ventricular tachycardia? Or say, is this another tachyarrhythmia with aberrancy? So like a bundle branch block, right? So starting to think through it, and we'll just go from there, right? So let's briefly just scan through the morphology of these QRS complexes. You can see that they do have, if they were going to have a certain bundle branch block morphology, it would maybe be a left bundle branch block. But at the same time, my QRS, if I look at my axis, we're going to kind of skip there just to start to develop the framework. You see that in lead 2, lead AVF, in lead 3, I've got negative QRS complexes. So that tells me that my axis of depolarization is going from inferior to superior and from right to left because they're positive in lead 1 and AVL. So I'm still like, I don't know, is this VTAC? Is this a bundle branch block? We really got to work through it. And also, guys, this is just one EKG. This is also one snapshot in time. In the clinical setting, you are going to reevaluate your patients and maintain clinical judgment. So here we've got that. Let's look for atrial activity, right? So let's confirm if there's any atrial activity. You know that in VTAC there's AV dissociation, but in an atrial arrhythmia, there's going to be a P wave for those QRS complexes. And if you look, say in V1, I do have what appears to be P waves in front of all of my QRS complexes. And if I scan through the entire strip, I also see P waves the entire time. The P waves are sharp deflections, whereas T waves are nice and broad deflections. So, okay, maybe there is some atrial activity. If I look in lead 1 to determine the morphology of those P waves, the P waves are upright in lead 1, and in AVF, right here, they are also upright. So that tells me that, there might actually be a P wave coming from the sinus node heading down into the left, generating an upright P wave in lead 1 and AVF. So could this be a sinus tachycardia, right? We're just gathering more data. And so maybe let's determine if it is coming from the sinus node. I would expect for my AV node or my PR interval to behave the same way every single time. And so we can look at my PR interval, and you can see here, we'll do it in lead 2 down here. My PR interval, P wave starts here, my QR starts here. I have a normal PR interval. My PR interval is maybe 160 milliseconds, which is normal, in between 120 and 200 milliseconds. And now I need to figure out, does that PR interval stay consistent the entire time? If it doesn't, that might make me think this isn't the rhythm I expect it to be. And so I look through and I see, yeah, it looks like my PR intervals really are staying good. You can see a little bit of a artifact there, but you can see nice PR intervals in V1. This is V1. V1 always has nice, sharp P waves. Okay, so it looks like this is actually coming from the sinus node. So evaluate that QRS complex. We said the QRS complex was wide. We said it was greater than 120 milliseconds. And so now what we need to do is kind of work through, is this a left bundle branch block? And so left bundle branch blocks historically have late forces going towards the left ventricle, because in a left bundle branch block, you have a block in the left bundle, and then you get depolarization through to the right with cell to cell to the left. And so, yeah, you can actually see some slurry. You got to kind of see it to believe it sometimes. You can see this sharp initial deflection of the QRS, but then it kind of slurs on the way down. You can see it slurs just a little bit in that lateral lead 1, right there. And so that is really good indication that there are late forces going to the lateral aspect of the ventricular myocardium. So that's data for left bundle branch block. And then in V1, we also have no septal R wave. We have loss of the septal R wave. And remember that the left bundle supplies the septum for depolarization. And so usually there's a little R wave there, but we don't see that anymore. So yeah, you know what? This is all pretty good data that we have a left bundle branch block, especially in the setting of some sinus P waves. So far I'm thinking this is a sinus rhythm with a left bundle branch block. But why is the axis shifted left, right? We said that we have left axis deviation, right? We've got negative lead 2, lead 3, and AVF. Our QRSs are all negative. So that tells me that we've got an axis that is shifted way to the left. And so I look now, and maybe these pathological Q waves can tell me why. And if you look, the inferior leads all have pathological Q waves, deep Q waves. I don't see any positive deflections that start. Usually you look for a positive deflection before a QRS, and then there's no positive deflections. These are pathological Q waves, right? That tells me that the inferior myocardium down here is not really effective at transmitting signal. This person probably had a previous MI that affected the inferior aspect of their myocardium. And so now in the setting of not only that, but a left bundle branch block, this person is really driving forces to the left. That's why you get pretty extreme left axis deviation in this patient. So I hope that helps explain why we see that. Usually left bundle branch blocks don't cause a whole lot of left axis changes. So there is that. Let me get my microphone. Sorry, we're using this microphone. We're gonna plug it in so you guys can hear me better. So that's our left axis deviation. And so now let's figure out if we have any ST or T wave changes. Remember earlier we said that we have Scarbosa criteria to evaluate for ST and T wave changes. Here, fortunately, I don't see any of that. So I'm not going to go through Scarbosa criteria. I'll write it down so that you guys can look it up. Scarbosa, it's an O, criteria to look for ischemic changes. So don't see any of that here. So let's put this all together, and what do we get? We have a sinus tachycardia at a rate of 110 beats per minute. We have extreme left axis deviation, which can be explained by these pathological Q waves. And we also have a left bundle branch block. So I hope this helps you work through a little bit of the VTAC versus atrial arrhythmia with a bundle branch block. So, alrighty, now let's go to our next EKG here. This was a fun one. And I'm excited to go through this one because this is just a great rhythm. So, alrighty. First thing we're going to do, as always, we're going to get a general idea of what's going on. So I look down at my rhythm strip in V5. I see I've got a narrow complex rhythm that's pretty fast, right? It's narrow, it's fast, it's regular. Okay. And when I look, it seems to stay regular the entire time. I look at the rate. I find a QRS that lands on a solid line. We'll say this one does. My rate is 300, 150. That would be 100. So somewhere between 100 and 150, 140 beats per minute. So we have a rapid, narrow complex tachycardia. We're forming our differential diagnosis. This could be maybe atrial tachycardia, like an ectopic atrial tachycardia. It could be an SVT. It could be atrial flutter. Remember that atrial flutter? Usually the flutter waves occur maybe at a rate of 250 to 300 beats per minute. And so sometimes if you have 2-to-1 atrial flutter, you can get a ventricular rate of 140, right? You just cut that 250 to 300 in half. 140 is in that range. So include that in your differential diagnosis. And so now what we're going to do is we're going to work through our differential, figure out, is this a sinus tach? What's going on? I look for P waves, and I don't really see any discernible atrial activity that's preceding my QRS complexes, but I know I need to scan through multiple leads. V1 is usually a good lead. I don't see those nice sharp P waves that I expect in V1. So, okay, no P waves. Now I'm thinking, is this atrial flutter? Is it SVT? Well, in atrial flutter, you're going to see atrial activity. You're going to see fluttering activity. And so I'm starting to think, I wonder if this is SVT, right? It's a narrow complex QRS. I don't see P wave. So let's figure out, is there any signs of atrial depolarization, right? First thing we're going to do, though, is we're going to just make sure that the ventricular depolarization is going well. And so I see we've got this upright QRS complex in lead 1. In my QRS complex in AVF is isoelectric. So that tells me that it's going perpendicular to AVF towards lead 1. So that's a normal axis. So we have a normal QRS axis, right? Now we need to determine what's going on with this. So my differential diagnosis includes AV reentry tachycardia. So we'll write it here, 1 AV reentry tachycardia, which is caused by an accessory pathway that allows for a reentry circuit to go, say, this way, then back through the AV node, and then back through the ventricles. So it's AV reentry tachycardia. That will cause what we would call a long RP tachycardia. 2, we've got AV nodal reentry tachycardia, which is what happens there is you have reentry within the AV node itself, and every time it goes in a circle, it sends signal down to the ventricles, and then it comes back, sends a signal up to the atria, and then it does that over and over and over again. The difference between these two arrhythmias is the timing of the P wave in comparison to the R wave or the QRS. And so we would call AV and RT usually short RP tachycardia. And so why does this matter? Let's take a look at this rhythm, and I think this is going to be just such a great example of how to differentiate these two. So we're going to look at V1. So I'm going to zoom into just this V1 because it's a little bit better on the screen. And so this is V1. We're going to zoom in really closely. So this is V1. And so V1, what we notice is we have our sharp QRS complex, right? You see the QRS, it starts sharp, but then I've got this little R prime. That's an R prime, right? If you look at this R prime, what do R primes usually make us think about? Well, especially in V1, it makes us think of late signals coming to the ventricles on the right side, right? And so that's like is it an incomplete right bundle branch block? But if you look at those R prime waves, they're not continuous with the QRS complex, right? You can almost see, by zooming really close, you can almost see that there's an ending to the QRS complex. The QRS like ends, and then the R prime occurs. It's not continuous with that QRS complex. And so I think this is what we would call a pseudo R prime. This is not an incomplete right bundle branch block R prime. This is a pseudo R prime. And what does that mean? A pseudo R prime is actually retrograde atrial activation or atrial depolarization. Right, so it's retrograde atrial depolarization, and it's occurring just after the QRS complex. So the RP interval, the interval that is between the onset of our R wave and the onset of this atrial activity is short. We would call this a short RP interval. That tells me that once the ventricle is depolarized, there is a very quick turnaround to when the atria has retrograde depolarization. And that tells me that this is likely AV nodal reentry tachycardia because my AV node has two pathways, essentially like a fast pathway and a slow pathway. But regardless, you've got signal coming this way and going down to the ventricles, causing ventricular depolarization, and immediately turning around and coming back retrograde through the other pathway and sending signal retrograde into the atria and depolarizing the atria. And so that is what's causing our pseudo R prime, is this wave of depolarization. So that tells me that this is an AV nodal reentry tachycardia and not an AV reentry tachycardia where you would see a longer interval between the R wave and the P wave, or a long RP tachycardia. I have a full video on AV and RT where I draw out the specifics of how it actually happens, how it gets into a reentry circuit. If you go to the EKG masterclass playlist, it's on there. It's a really good video. I'm proud of it. But regardless, yeah, that's what we see here. So this person has AV nodal reentry tachycardia. Last thing we need to do is continue to go through our normal protocol. We look for pathological Q waves. I don't see any. We look for ST or T wave changes throughout that would be pathologic for ischemia or infarction. I don't see that. I look at my QT interval briefly. We see R to R halfway through there. You can see that T wave. And it's kind of close. It's not egregiously prolonged. So what do we have here? We have an AV nodal reentry tachycardia at a rate of 140 beats per minute. So I hope that helps. You'll see those pseudo R prime waves in V1 in AVR, and that is what ultimately clinched the diagnosis for us here. So that's a really fun rhythm. What do you do for these people? First, we localize where's the issue. We said it's in the AV node. So what can you do? You give an AV node blocking agent. You can block them by doing like a vagal maneuver. So vagal maneuver, that's like bearing down. So you can have someone blow on a syringe, like just increasing your intrathoracic pressure. Actually, like it decreases the preload to the heart, and it actually increases your parasympathetic vagal tone. And when you do that, the parasympathetic fibers that go to the AV node will actually tell it to essentially chill out, slow down. And you can actually convert this rhythm back to sinus, or you can give someone an AV nodal blocking agent such as adenosine, which will just cause abrupt stop of the AV node. The half-life of adenosine is like 5 or 10 seconds. It's really, really short. So adenosine will cause our AV node to halt for a few seconds, and then ideally the AV node, or excuse me, the SA node that's been suppressed by all of these retrograde P waves can have time to take back over. So pretty neat stuff. All right, so that's that one. Let me go through the questions real quick. How do you tell the difference between a pathological Q wave and a deep S wave? Yeah, so remember that an S wave, I think we have a great answer. An S wave must occur after an R wave, and an R wave is a positive deflection. So you cannot technically call a negative deflection a Q wave unless it happens first. So if the first deflection of a QRS is negative, that's a Q wave, versus an S wave is after a positive deflection. So another question, what if you can't shock them out of SVT? Right, so I said vagal maneuvers, adenosine. Obviously, you can also give these people electricity. You have to always, if something is not working in medicine, the best thing to do is to take a step back and reform your differential diagnosis, right? Here, we're saying this is a narrow complex tachyarrhythmia, AVNRT, AVRT. There's always a chance that this is some rare different arrhythmia, like 2-to-1A flutter. Really unlikely in this case, but if you're shocking them and it's not working, why is it not working? What are their electrolytes? What medications are already on board? Are they on, have they been taking stimulants? Maybe they took a lot of methamphetamines or cocaine, or think through why this rhythm is not responding to the treatments of choice. So take a step back, reform your differential, and go from there. So there are plenty of things that can cause excitability of the heart that would confound or make this rhythm more difficult to treat. And so I would do that. So when you consider a Q wave to be pathologic, that's a good question. So the depth of the Q wave matters. There's criteria for it. I can't remember the name of the criteria. What is the criteria name? That's going to drive me crazy. Sorry, I can't remember the criteria name. I'll throw it in the comments. And that'll just help you. But ultimately, it has to do with the degree of the Q wave compared to the rest of the QRS complex. So if you have significant positive forces headed in that direction of that lead, and then the Q wave is maybe like very small in relation to that, that's where you're going to say pathologic. You're also not going to have something that I think is really interesting with pathological Q waves is you're really very rarely going to have purely isolated pathological Q waves, right? So say I have in my inferior leads are leads 2, leads 3, and leads AVF, right? And if I'm going to also highlight my heart here, lead 2, 3, and AVF, the interesting thing about pathological Q waves, it tells me that there has been a previous myocardial infarction. How likely is it that that previous MI only is like just right here over top of one lead? Very rarely. So usually, if we look at our vascular anatomy of our right coronary, our left main with our branches of the LAD and the circumflex and all of their distal branches, we can understand which leads would represent an area of a previous infarction. And so when you look at a pathological Q wave, you're really not going to see just a lead 3 pathological Q wave because that infarction likely is going to also be captured by AVF in lead 2, usually to different degrees. We know that lead 3 in, say, an RCA infarction usually has the most ST changes, and it's likely going to have a deeper pathological Q wave because it's mostly representing that depolarization. So when you see a pathological Q wave, it's not so much on like how deep is this Q wave, right? Ultimately, you have to correlate that to the surrounding leads, look at the QRS axis, and look at in this case, if you're looking in lead 3, look at AVF. In lead 2, you should also see pathological Q waves to a different degree. That might tell you that, to me, looks like RCA distribution, previous myocardial infarction. So good question. I'm not going to put a number on it because everybody's different, right? QRS amplitude is confounded by so many things. If somebody has COPD where they've got this big barrel chest, well, if my lungs are big and barreled, the leads are going to be farther away from my heart. And so I'm going to have, less of a QRS amplitude. Same thing if I'm obese, if I've got pericardial disease, effusions, all sorts of things. So really it's all about just putting the clinical picture together. And in this case, you could also include the risk factors for all those confounders. So, alrighty. Let's move on to the next. Thanks for all your questions. And if you're joining, let me know where you're joining from. Like I said, it's fun to build community. It's fun to build ECG community. And so let us know where you're all joining from in our common ground of EKGs. So, alrighty, we are on, I think, the second to last one. So let's roll through this. Greece. I can't remember anything in Greek, but I've been to Greece and it was great. So thanks for joining from Greece. It's a beautiful country and the people are beautiful. So nice. Alrighty, so let's jump into this one. This is a really fun one. This is a complex one. I think it's a lot of good lessons to learn. So let's take a look and get an idea of what's going on with this rhythm and look at the forest. And the trees of the forest are my QRS complexes. So I look down here in lead 2, and I see I've got a regular rhythm. And you can see that rhythm stays regular throughout the entirety of this strip. It almost seems like it's narrow, but if I look really closely, my QRS starts here and it ends maybe there. So I would say that's actually a wide QRS, right? My QRS here is greater than 3 small boxes. It's just greater than 3 small boxes, or greater than 120 milliseconds. So that's a wide complex QRS, and it's regular. My rate of my QRS complex is if I find one that lands on a solid line, I go 300, 150, 100, 75, 60. That would be 50. So it's just faster than 50. I'm going to call this maybe 52 beats per minute. So I've got a 52 beat per minute rhythm, which we would call that a bradycardia or a bradyarrhythmia. And so what do I think through when I see a bradycardia that is specifically wide in nature? One, I wonder, is this an escape rhythm, right, where you have a ventricular escape or an escape with aberrancy? Or is this a sinus bradycardia? Or this will also kind of be part of your differential diagnosis of being an escape rhythm. Escape rhythm could occur because of an AV block, right? So, or is this some degree of AV block, right? And so we got to think through what causes our bradyarrhythmias. Let's look for atrial activity in front of these wide complex QRSs, and I do see P waves. I see P waves in front of my QRSs. If you scan through, I got P waves throughout all of my QRS complexes, and those P waves are upright in lead 1. They're upright in AVF, so it tells me that my P waves are traveling down and to the left. And so, yeah, looks like we have sinus P waves. It doesn't mean that this is a sinus rhythm yet. We haven't confirmed that. It means that the P waves, the atrial activity, is coming from the sinus node. The next thing in our conduction system is our PR interval, or the AV node. And so now we get to determine, is the sinus P wave that we are tracking here, is it delivering those signals to the QRS complex via the AV node? And so I look at my PR interval, and maybe we'll go down to lead V1. We'll just choose this one. And so if I look at my beginning of my P wave, beginning of my QRS, my PR interval is in between 120 and 200 milliseconds, which is normal. And now I need to figure out if every single P wave conducts to a QRS in that same fashion. And so I look and I see it sure does when I see my QRS complexes. So I'm certainly thinking now that my sinus beat is sending the signal to the AV node, but like always, we need to make sure that there are no P waves that are without a QRS complex, right? Our differential diagnosis includes AV block. And if it's a second degree AV block, that means that some, but not all, of those P waves are being conducted to the QRS complex. So I personally like lead V1. Usually V1 has pretty good P waves. And so I look through here and I want to scan through and look for atrial activity. And so I see maybe that sharp bit of activity. And I wonder, maybe that's P wave. Well, it should replicate. And if you look, I've got P waves with every other QRS complex that are not associated with a QRS. And so that to me makes me think, I wonder, is this a 2-to-1 AV block, right? Some of you might be like, is this a T wave? Why is this not a T wave? Remember, P waves are very sharp. These are very sharp deflections, whereas, for example, this T wave is nice and flat and smooth. My P wave is nice and sharp. Also remember that we're just looking at one lead. We're just looking at V1. This should be occurring in other leads. So let's look at other leads. Let's go up to lead 1, where we have these nice sharp P waves. And so now, look at that. There's that sharp P wave that is not associated with a QRS. Then there's another one. And so I'm getting more evidence that we are getting P waves that are without QRS complexes. And so when it happens with every other beat, that tells me that this is a 2-to-1. That means there are 2 P waves. So there are 2 P waves for every 1 QRS. So it's a 2-to-1 AV block. Okay. Let's classify this even further, right? AV blocks that have some P waves conduct QRSs, but some P waves don't. This is going to be a second degree AV block, right? That's what first degree, PR interval is just too long, but it conducts every time. Third degree, there's P waves, there's QRSs, but none of them are talking. They're just kind of happening independently of each other. Second degree, some of them are doing that. We know that second degree, you've got type 1, you've got type 2, and then you've got something called high grade. Type 1, so type 1, you have what? Your PR interval increases with each beat until it drops, right? Type 2, second degree blocks, your PR interval stays the same or equal until it drops, right? In order to say that a PR interval has stayed the same or has stayed equal, you need to have consecutive beats where the P wave conducts to a QRS to determine, has my PR interval changed? We don't have the luxury of that on this rhythm, right? Because we don't have two consecutive P waves that conduct to a QRS. So we don't know if the PR interval is lengthening in a type 1 second degree or staying the same in a type 2 second degree. So some people call this a type 2 second degree AV block. You really can't. So what I call this is a second degree, quote, high grade AV block with 2-to-1 conduction, right? That's a little bit more just saying, look, we don't know if the PR interval will be changing or not. We can trend this if this person's on telemetry or like some type of cardiac monitor. You can trend it and you can see maybe it'll change, and maybe you see evidence of that type 1 or evidence of that type 2, and you can change the diagnosis. But in this case, you don't get that. So we call this a second degree high grade AV block for that reason. And the reason why it matters is because type 1 second degree AV blocks, type 1 is disease of AV node proper. Type 2 is disease of our His fibers, His Purkinje fibers, because type 1 is evidence of decremental conduction, where the PR interval gets worse and worse and worse till it drops. Type 2, which is a His Purkinje system, is what we would call all or nothing depolarization. So either does it or it doesn't. And type 2 second degree AV blocks is not very good. You need pretty urgent / emergent pacemaker insertion, whereas type 1, you don't. And there's a lot of reasons why. I outline those in another lecture. I think it's important to go and check that out as well. Go to the master class, like EKG curriculum playlist, and check it out for a little bit more details. So, okay, we're not done. We said we've got this high grade AV block. Now we get to evaluate my QRS complex. And so we get to look at the morphology of my QRS. We said it was wide. It's a QRS that's greater than 120 milliseconds. Let's look at the axis of my QRS. It's upright in lead 1, but it's down going in AVF. So you see we've got this left axis deviation. So my axis is going up and to the left. So we've got left axis deviation. Okay. So what causes left axis deviation in the setting of a wide complex QRS? It could be a left bundle branch block. It could be left ventricular hypertrophy. I don't see any of that here. And interestingly, what I see is if I go into V1, because we said it's a wide complex rhythm, so we're looking for bundle branch blocks. Why would this rhythm that's being driven by the sinus node, not, if it's wide, not have an aberrant morphology? So what I'm going to do is I look for bundle branch block morphology. I didn't see a left bundle branch block morphology, but I see actually evidence of a right bundle branch block where you have this R prime, right? That's an R prime. This right here is your R prime. So I've actually got a right bundle branch block. You can see more evidence of that with the slurred S wave in lead 1, in lead AVL, right? That's a slurred S wave. Slurred S wave. Why do we get slurred S waves in right bundle branch blocks? Well, if the right bundle branch is blocked, dysfunctional, I get rapid depolarization through to the left ventricle. And then at the end of my QRS, later, I get cell to cell, slow, gap junction to gap junction, depolarization away, negatively away from the lateral lead. So you actually get a slurred S wave. That's what that's representing. So we have that here. And we have right bundle branch block with left axis deviation. So we have a right bundle branch block with left axis deviation. And if you look, you can see in lead 3, I've got this little r big S morphology. So when you have left axis deviation in the setting of right bundle branch block, and I've got this evidence of little r big S morphology, right? I'll draw it like that. That tells me there's also a left anterior fascicular block. Whew, that's a mouthful. So we have a bifascicular block, right? Bifascicular bifascicular block. So this person has a bifascicular block, meaning that they've got, in this case, a right bundle branch block and a left anterior fascicular block. And they've got 2-to-1 AV block. Some people would call this a trifascicular block. There's a lot of blocks. This person's conduction system is not very healthy. This person is very well on their way of requiring a dual chamber pacemaker to make sure that the ventricles will be paced when the AV node is no longer working. Their conduction system is diseased. So they've got a bifascicular block. Remember, there's two fascicles. There's the left anterior fascicle and the left posterior fascicle that come off of the left bundle branch itself. Those can be blocked, and I make some videos on that too. I don't want to dive super deep into those because they're pretty confusing if you don't have really good anatomy drawings. But really just remember that the left anterior fascicle is kind of on the anterior lateral wall, and the left posterior fascicle is kind of like the inferoseptal wall. And when they get blocked, you get these characteristic patterns in lead 1 and lead 3, which we have here. So I have lectures on those. I keep telling you to go watch them, but I do want you to watch them. They're good, and at least I think they're good. And if you like what we do, I think you'll like these videos. So, alrighty. Greetings from Indonesia. Hey, thank you so much for joining. If you just signed in, let me know where you're listening from so that we can all connect on common ground on EKGs. So, all right, and the last thing we're going to do with this one is we're going to look for pathological Q waves, and we're going to look for ST and T wave changes throughout, right? This person could still have ischemia. Very fortunately, I don't see that here. So this is certainly a chronic process. And so what do we get? We have a sinus rhythm with 2-to-1 high-grade second-degree AV block, creating a ventricular response or ventricular rate of 52 beats per minute. So we have this bradycardic rhythm that is being that is a byproduct of that block. And you also have within the ventricular conduction system evidence of bifascicular block, where we have right bundle branch block as well as left axis deviation in our little r big S. So tons of blocks, and it's exciting. So let's get this guy or patient here, a pacemaker, and go from there. So that's our second to last one. Greetings from London. Howdy. I've never been to London, never been to Indonesia, but I would love to. I've only heard great things. Alrighty. This is our last EKG of the day. Remember, if you want to follow along, the link in the description is to the Patreon website, which is my only website. I'm not tech savvy enough to make my own, but I did it because it just helps with PDF uploads and organization. So download them, just join for free, and you can also get daily EKG challenges on there. So I wanted to give you something if you're going to make an account. So quick question: why is the third beat in V5 different than the others? Let's take a look. Third beat in V5. Is that one? Let's see at the bottom. Oh, good question. So this one right here is what the question's referring to, the third beat in V5. Remember that when you see a weird beat, we would say that's a funky beat. Compare it to other leads. Oftentimes, it's artifact. An artifact can be caused by, many different, movements, right? V5 is here, kind of near the left, like mid-axillary line. It's just anterior to the left mid-axillary line. So somebody could have bumped it. Somebody could have sneezed. And what you want to do is, if you see that that's funky and you're worried about it, just compare it to the other beats. Remember, all of these beats that are in line with it are also the same beat. And so if you want to compare it, that's going to give you some peace of mind if that is truly an aberrant conduction setup or scenario, or if it's just artifact. And sometimes if you look really closely, you can just see that pretty QRS complex that looks just like the other ones. So, and you can kind of see through a little bit of that, and it's right on time. So everything points towards artifact here. Great question. Sometimes artifact can kind of freak people out. You're like, is that a PVC? Was that VTAC? Sometimes if someone has like a tremor, like someone's like Parkinsonian or has an essential tremor in if their arm is tremoring and you got a lead on your arm, you might see like a fibrillation or this tachyarrhythmia that it's not really a tachyarrhythmia. So great question. Alrighty. Last EKG. And if you haven't already, if you enjoy the content, y'all, first of all, thanks for your support, your comments. I love them. If you have questions on other videos, please continue to comment. Let me know feedback on how I can make this channel better. I just want it to be useful. I want it to be a go-to free resource. I don't want all these crazy paywalls. And I think EKGs are really important concepts for people in all sorts of fields. If you're going into family medicine, internal medicine, surgery, obviously, if you have aspirations to be a paramedic or a nurse, like those are all great reasons to master the EKG so that we can be good at our jobs and our professions. So if you enjoy the content, subscribe to the YouTube channel, go become a free member of the Patreon, comment on the post, be a part of the community, and we can all get better at EKGs together. I'm going to continue to work on providing just consistent videos, consistent, different avenues for you to get your EKG needs, whether it's pushing the free ECG daily challenge on the Patreon, whatever it may be. So thanks again. All righty. Last rhythm. This is another fun one. Let's take a look at it. So the first thing we're going to do is we're going to look at the forced. Come down here to V5, and I see I've got this regular tachyarrhythmia, it appears. Narrow complex, and it seems to stay regular the entire strip. If I look a little bit more closely, just to verify, you can see my QRS duration. My QRS is certainly narrow, right? Less than 120 milliseconds. And it's regular. What's the rate? So say I find a QRS that lands on a solid line. We'll say this one's close enough. We go 300, 150, 100. This lands in between 100 and 150. I would call this maybe 140 on the eyeball test, beats per minute. Quick little tip or trick. If you're like, I want a better eyeball test, try doing this. Find another QRS that lands on a solid line. And I'll come over here and count the rate of 2 beats and not just 1. So say I want to count from there to this one, and I go 300, 150, 100, 75. This would be 60, so a little bit faster than 60. Say 62 beats per minute in between those two, and then just multiply that by 2, and what do you get? You get 124 beats per minute. So it's a little bit more accurate. So it's a great example of how you can change the span of what you're counting, and you get a better answer. So we have a rhythm now that's at 124 beats per minute. It's narrow, it's regular. What's my differential diagnosis for this? It could be, say, sinus tachycardia. It could be ectopic atrial tachycardia. It could be SVT. It could be, atrial flutter, right? And so we'll try to figure out why this rhythm is happening this way. So I look for my atrial activity, and what I do is I look for P waves, and I love V1. I think V1 is the best for P waves. And I look in front of my QRS complexes, and I think I might see some atrial activity, right? Atrial activity is usually sharp. And so what you're going to do is you see certainly some sharp deflections there. So they do seem like they are atrial in nature, right? And so I'm thinking, okay, that's good. But are they sinus P waves? Are they coming from the sinus node? I look up here in lead 1, and I look here in AVF, and I don't know if I can say with confidence that I see a P wave that is distinctly upright in those leads. Matter of fact, I would say that this is kind of a downsloping set of atrial activity. And so I'm like, okay, this atrial activity is not sinus in nature. So what could it be? Well, it could be ectopic. It could be atrial flutter. And 2-to-1 atrial flutter, which if it was atrial flutter, it'd be 2-to-1 in this case, is hard because the QRS complexes are so close to each other that you don't have enough space in time to actually see the flutter waves. So sometimes you have to see it to believe it. You also have to understand, what is it not, right? So is it AV reentry tachycardia? Is it AV nodal reentry tachycardia? Is it ectopic atrial tachycardia? Is it multifocal atrial tachycardia? Is it sinus tachycardia? Right? All of those things, right? We said it's not sinus, so we need to keep saying, what is it not? Well, I don't see ectopic P waves in the sense that I don't see if I scan through all of my leads, I don't see a P wave that is distinct and coming from a region that is ectopic. So I don't see ectopic atrial activity. AV nodal reentry tachycardia could be that. 124 is pretty slow for an AV nodal reentry tachycardia. Usually you would think of at least around 150 beats per minute or more. I know we had an example earlier where it wasn't. That's okay. Not everything fits the rule book. And you would see remember those pseudo R prime waves? I don't know if I see it necessarily a pseudo R prime. Doesn't really make me think that way. AV reentry tachycardia, remember that's a long RP tachycardia. I don't see a P wave that makes me think of a long RP because you have to have a nice distinct P wave for that correlates. So what do I land on? Is this 2-to-1 atrial flutter? When you look here in your inferior leads, lead 3 is a pretty good one for flutter waves. What you're going to notice, and I'll do this in red, is I've got this wave. And if you look, there's a little deflection up before that QRS complex. And then we have another deflection, and then we have another deflection up, another deflection up. So if you can see through this arrhythmia, you can almost tell that there is this sawtooth pattern, this flutter pattern that is driving through the rhythm. And really the best way I think to look at it is to see this little upward deflection, right? That flutter wave is cutting through that QRS complex. And so I'm starting to think this is maybe atrial flutter. You can see it here in lead 2, flutter wave. And remember, the flutter waves that are here, this yellow flutter wave, I'll draw it actually in green. This green flutter wave, it's also superimposed on the T wave. So it's going to look different. Not all the flutter waves are going to look the same. The flutter waves that are happening at the same time as ventricular repolarization are not going to look the same. Remember that atrial flutter, if I zoom into this heart, is generally a rhythm that occurs via a reentry circuit around, this is the tricuspid annulus. The tricuspid, meaning tricuspid valve, which is the valve between the right atrium and right ventricle, and annulus, which is like annulus, like ring, right? So there's this ring that forms around the tricuspid valve in between the inferior vena cava and the coronary sinus where it enters into the right atria, and it actually forms this reentry circuit. And so what you can have is reentry along there. And every time it reenters, it sends a wave of depolarization. And that wave of depolarization, if you notice, it's kind of going up a little bit. You're going to have negative flutter waves in the inferior leads. And you can see that here. If I erase this again, you can see all of our flutter waves are, in fact, they're sloping down, 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 right? And so those are our negative flutter waves from usually what we'd call this typical or common atrial flutter around the tricuspid annulus. So I think based off of what we went through with this list and eliminating all of our options, I would say this is atrial flutter with 2-to-1 AV conduction, meaning 2 flutter waves per 1 QRS complex, right? That's 2-to-1 atrial flutter at a rate of 124 beats per minute. But we're not done. We need to evaluate our QRS complex. We need to be thorough. We got the QRS morphology. We said it's narrow. It was less than 120 milliseconds. My QRS is isoelectric in lead 1, and it's positive in AVF. So it tells me it's perpendicular to lead 1. So my QRS axis is going straight down towards AVF. That's positive 90 degrees. That's a normal axis. And we need to look for our QT interval. And so hard to tell with the flutter waves, but if you find 2 R to Rs, connect them, draw a line down the midline. And for the most part, I might not have done that perfectly in the middle, but those T waves seem to be completed around that middle of the R to R intervals. And The last thing we're going to do is look for pathological Q waves for any previous MIs. I don't see any. We're going to look for ST and T wave changes throughout. ST and T wave in a tachyarrhythmia like this, sometimes you'll see some diffuse ST depression, right? Indicating diffuse subendocardial ischemia. That's because it's a supply demand. So when the heart is beating so fast, remember that the heart, every time it contracts, it's systole, and every time it relaxes diastole. When it relaxes, that's when those vessels that are penetrating from the epicardium to endocardium that are supplying the heart with oxygen are filling and delivering, perfusing the ventricular myocardium. When you're going so fast, the amount of time you are spending in diastole is less. So when you're spending less time in diastole, you're going to have less perfusion, but you have an increase in demand because you're beating so fast. So sometimes you will get some diffuse ST T wave changes because those distal areas that are distal to those epicardial vessels, which is the subendocardium, just the endocardial region, they get a little bit ischemic while this rate is so high. So sometimes you'll see some diffuse ST depression. Don't really see anything that jumps out at me here. But when you slow it down in those folks, you'll see that ST segment usually go back in these tachyarrhythmias to a baseline. So we put it all together, and what do we get? We get atrial flutter with 2-to-1 conduction. So quick question before we head out of here. How do you terminate flutter with 1-to-1 conduction? And what would a normal AV node, conduct flutter 1-to-1? That's a great question. 1-to-1 flutter is scary. So let's talk about 1-to-1 atrial flutter really quickly. It is very rare, first of all. It's a great question. Very rare. 1-to-1 flutter. So first, for all of y'all who are new to atrial flutter, 2-to-1 flutter means that we go around one time and we send a wave through. And then we go around a second time, we send another wave through, and that's the wave that gets sent down. So every 2 trips around this reentry pathway, you get one wave of depolarization, right? Remember, the AV node is essentially a bystander in atrial flutter. It's the atria that are fluttering, sending signals rhythmically at an atrial rate of 200 to 300 beats per minute. And so usually the AV node, thank God, doesn't send that signal down every single time. It gives the ventricle some time to fill. In 1-to-1 atrial flutter, that means that if it's 1-to-1, that means for every 1 reentry, you get 1 signal down, and that's going to cause a rapid tachyarrhythmia. That very rarely happens in real life. The times that it does happen are when the reentry pathway is slowed down. So when this reentry pathway, usually flutter waves are fast, right? 250 to 300 beats per minute, right? That's usually the atrial rate in an atrial flutter. If you wanted to, you could actually count 2 flutter waves here and you could determine the rate, right? So because it's going so fast, the AV node passes down every other signal. If you give someone a drug that slows down myocardial conduction of signals, if you slow down that rate, so if you slow it down to say 200 to 250 beats per minute, you might be giving the AV node time to conduct each of those down at a 1-to-1 ratio, right? So things that slow down conduction, we think of sodium channel blockers, right? Flecainide. Flecainide is like the drug you do not want to give to somebody with a history of atrial flutter or risk factors for atrial flutter. You don't really want to give flecainide at all because remember, sodium is responsible for those voltage-gated sodium channels, allows for sodium to rush in and depolarize the cell. So you give sodium channel blockers, that could slow down conduction. What are other drugs that also block sodium channels? You think of, obviously, the antiarrhythmics, like we said, with flecainide. So we'll write flecainide. You also have drugs that are like tricyclic antidepressants, right? Amitriptyline. Those can do that. You've also got cocaine, right? Cocaine was once used as a local anesthetic because local anesthetics like lidocaine, which is also a class 1 antiarrhythmic, a sodium channel blocker, cocaine also blocks sodium channel. So if somebody has overdosed or taken a lot of cocaine, they could slow down conduction enough to the point where they will have 1-to-1 atrial flutter if they are an atrial flutter. So I hope that helps. How do you terminate flutter with 1-1 conduction? You give them sodium bicarbonate. They have any of these sodium channel blockers on board. You give sodium bicarb, sodium HCH. What is it? I can't. I'm like drawing. I'm like having a moment. CO3. If I did that wrong, guys, I've had so much coffee. Sodium bicarb. You can give them sodium if they have one of these overdoses, or you can shock them. So shock them. Also, just think through, why is their myocardium so excited? And you can also give AV nodal blockers, right? Diltiazem, verapamil, amiodarone. So thinking about either one, addressing the primary cause, or two, slowing down that AV node, because that AV node, if it's sending all the signals down, we ought to slow that down if it's 2-to-1 atrial flutter. So again, everybody, thanks so much for your participation. This has been really fun. And I love teaching EKGs. They're challenging, but they're really interesting, and they help you understand, learning the EKG is really learning physiology. And so if you have questions, post them to the comment section of this video, to other videos. Thanks to everyone who tuned in. Don't forget that we've got the Patreon where you can download the EKGs. You can see the daily EKG challenge. And if you find value in the channel, please consider liking the videos, commenting, subscribing to the channel. It's the best way for our channel to get out there and for people to see and learn. So thanks so much. Thank you all. And take care. Have a good rest of your day, and keep doing all the EKG fun stuff. See you on the next video.